Right. So as we know, COVID, we are now almost a year, more than a year. And if you look at Wuhan, it was October, November when the first cases started coming. India's first case was, if I'm not mistaken, on the 20th of January. So we are more than a year since COVID, and we know what a year it has been. A year which has been very, very different. This COVID dashboard shows India's death rate as 9.5, incidence of 9.5. And I can show you the current incidence as it stands few days ago. And as you can see, the number of deceased is 153,000 with 10 million cases. Having said that, remember India is the second most populous country in the world. I'm just trying to move the slides. Yeah. And we also know that the highest incidence COVID is in the scene in the ages above 50, 60, in the 70 bracket. And we know that it is differentiating. It differentially affects the patients who are more elderly. We also know that in countries in the West, it has differentially affected ethnic minorities. If you look at the case fatality rate in India, it is 1.5%. And no matter what you say about the planning and how it has been conducted, I would say that India has been a stellar success. If you compare to the mayhem, if you compare to what has happened in the West and is going on still in the US, UK, and the Europe, India is a star example. And there are many reasons. So the mortality rate for the size of India is 1.5% despite the drawbacks within the system. So we'll touch upon it in due course. And we already know that the vaccination program is going very well, and many of you have already been vaccinated. So let us go through the problems in terms of coagulopathy. We are aware about the primary symptoms of COVID-19, headache, cough, sore throat, and the various as mentioned on this slide, as well as the extra pulmonary manifestations. And I would take you to the area about thromboembolism. Let me just get my pointer. DVT, PE, and catheter-related thrombosis, as well as the arterial thrombosis. So let me remind you some of the concepts about hemostasis and sepsis. As you are aware, coagulation system evolved as an effector pathway of the immune response. Essentially, it was laying fibrin around bacteria to physically entrap them and prevents its dissemination. And as you are all aware, the endpoint of inflammation is thrombosis. And we see that with vasculitis, we see that with Behçet's. And we are aware about that in vasculitis, the treatment is not antithrombotic treatment, it is the treatment of the inflammatory process. In COVID, in addition to inflammation, we also have the complication of hypoxia. And as you are aware, in hypoxia, you have the secretion of hypoxia-inducible transcription factor, HIF, which also creates a prothrombotic state with release of tissue factors and PI1 genes. And this, as you know, as you are aware, the receptor for COVID is ACE2, present in the lung, the pulmonary epithelium. It is also present in endothelium, in the GI tract, as well as it has been seen on the cardiac endothelium as well. As you are aware, majority, 95% patients are asymptomatic or have minor infection. Tiny proportion end up with severe COVID pneumonia with massive inflammatory response, the cytokine storm. Of these, another tiny proportion become severely unwell, requiring mechanical ventilation, and it results in a prothrombotic state due to release of cytokines IL-1, IL-6. However, you have to remember that there are other comorbidities and confounding factors. As we are aware, in the West, there is a very high incidence of obesity, and it is increasing in India as well. And obesity is an inflammatory state because of the release of inflammatory cytokines. So what is the problem in COVID? In COVID, you have what we call immunothrombosis because of the direct infection of pneumocytes. This results in increased permeability, activation of the various inflammatory cells, that is T cells, neutrophils, monocytes, a cytokine storm including IL-1, 6, 10, TNF-alpha, resulting in microvascular thrombi. and eventually causing macrovascular thrombi. And as you have seen, and you have probably, those who do pathology have probably encountered in the autopsy samples, that lungs become rock solid, and you see microthrombi, and you see the damage that has been caused due to fibrosis as well. As we are all aware from our medical school, thrombosis happens when there is an endothelial injury, there is hypercoagulability, and there is stasis of blood flow. So this thrombosis in COVID has two different phenomena. One, I'm just going to take this slightly away. First is the inflammation in the pulmonary vasculature, formation of microthrombosis, and secondly, the more conventional thrombosis, which we see with DVT, embolization, and PE. So you have both of this interplay going on. And this is the spectrum. On one hand, you have the spectrum of thrombosis, and on the other hand, you have the spectrum of inflammation. So if you ask me, where does COVID stand? COVID starts off as an immunothrombosis, and the various patient-related factors such as obesity, diabetes, immobilization, comorbidities start playing in, and the spectrum moves towards thrombotic state. So it is a immunothrombosis moving to a secondary thrombosis state. However, there are some papers, especially from China, Wuhan, where they have shown presence of antiphospholipid antibodies. And I would briefly mention that antiphospholipid antibodies are seen with any viral infection. Hence, you require more data to suggest that the thrombosis in COVID is due to APL. I would say that there is no evidence that there is antiphospholipid antibodies contributing. This paper was roundly criticized because it did not demonstrate the laboratory parameters. It didn't demonstrate the presence of lupus anticoagulant. So why is the D-dimer so high? And what is the prognosis in terms in COVID because of the D-dimer? As you are aware, D-dimer is a fibrin degradation product. It is due to the breakdown of fibrinogen to fibrin and fibrin to FTP due to the action of plasmin. As you are aware, in the lung, when there is acute lung injury, there is release of urokinase, what we call as UPA, from the pneumocytes. And this causes a huge release to regulate the extravascular proteolysis by PI1. And this has been demonstrated very effectively. However, in COVID, it is not just the pneumocytes, there is also activation by monocytes, macrophages. So in addition to urokinase, there is generation of plasmin and metalloproteinases, which causes fibrinogen binding to CD11b, CD18, which gets internalized into lysosome and is degraded by cathepsin D. So these two complications lead to a logarithmic rise in D-dimer, and this logarithmic rise in D-dimer is reflected in the patients. So it is a marker of immunothrombosis. It is a marker of injury that is happening at the alveolar level. And when I come to the laboratory parameters, I'll explain why COVID thrombosis is different from sepsis-induced coagulopathy. We know that everybody who has treated COVID, and we know from our own experience that the thrombotic complications are high. In China, they saw it in 7% patients which was high risk, and the incidence was 11%. However, there is a drawback. In China, they were not using thromboprophylaxis in all patients. So they were very selective in offering thrombosis, and hence the incidence was higher. There is another data which showed that there was as high as 27% of VTE with 3.7% of arterial thrombosis. If you look at the burden of thrombosis in the various countries reported, it ranges from 20 to 69%. Even if you take a standard of 20%, remember, thrombosis is a common complication in hospitalized patients. Thrombosis happens due to immobilization, medical illness, multi-organ failure. So the background incidence in ICU patients of thrombosis is 6 to 10%. So you can safely assume that the incidence of thrombosis is 2 times or 3 times of any other ICU patient. However, there is also some data in children If you look at the column on the right, hematologic and thrombotic complications, 76%. However, this data includes hematological complications. It is not only thrombotic. So this can be seen in children in what we call as the multi-inflammatory syndrome seen in children, MIC. However, there is some criticism in terms of what is counted as thrombosis. In that 20%, many of these cases include segmental and subsegmental thrombosis picked up on PET-CT and CT scan. Now, if you look at immunothrombosis, that manifests itself as segmental or subsegmental thrombosis, and these particular pathophysiology does not respond to anticoagulation. It responds to anti-inflammatory drugs. Hence, within the hematology circle, there is a belief that the incidence of thrombosis actually may be in the range of 5 to 10%, and what is often reported as thrombosis on the lung is a reflection of immunothrombosis. The effect of anti-inflammatory drugs, specifically dexamethasone, which is now a standard practice since the recovery study, as well as the role of remdesivir, the recent introduction of monoclonals and combination of monoclonals, we have to see the impact of this immunothrombosis, whether it improves, and also the secondary effect of fibrosis. So that's evaluation. A lot of data is still coming, and it is the hypothesis is that some of these anti-inflammatory, antiviral drugs will result in lower long-term disease burden. So coming to the laboratory parameters, we know fibrinogen, D-dimer, procalcitonin, ferritin, and CRP. These are all affected. They are all going, they are synchronous, they all go up. They are inflammatory markers. However, there is a slight difference in COVID immunothrombosis compared to sepsis-induced coagulopathy. And the main difference is in sepsis-induced coagulopathy, the fibrinogen drops very low, the platelet count drops very low, and in COVID, usually the platelet count does not drop below 100, or in tiny proportion it drops below 100, and fibrinogen in many patients is high rather than low. Yet, some people may call it DIC. It is not DIC, it is COVID coagulopathy, and that is essentially due to the D-dimer rise seen due to the factors that mentioned earlier, because of the role of pneumocytes and as monocytes, macrophages in immunothrombosis. So these are the various predictors of thrombosis. These are the standard parameters, as we are aware. And there is some more data on the genetic part. Why are some people or some patients more prone? Now, as you know, as the COVID mortality, as you see, even in the US and UK, the things are still not under control, almost out of control in many parts of the world. The reason is, number one, the latitudes may be playing a role. The northern and the temperate zones, both in the north and south, while in the tropical belt, maybe we are more protected. However, if you have Indians or South Asians living in US or UK, they lose that protection. In fact, the highest incidence of mortality is in ethnic minorities in those countries. So there are various reasons we are not aware. There was also some data which suggested that there is residual Neanderthal genes which may be contributed. So a lot of work is going on, and this is a paper that was presented in December, which looked at some of the genetic variants. And they found that there are several mutations who may have higher risk of thrombosis, especially related to COVID. So we know that some families, and there are some horror stories where we heard that in a single family, there have been multiple deaths, and the neighboring family, there are no deaths. So there is so COVID has been very differential. Some have been affected more than others. So this is the COVID triangle, the tip of the iceberg. Now, as you know, 95% patients are asymptomatic, 5% patients are symptomatic, and in these 5% patients, you have the secondary thrombosis through the known risk factors: age, immobilization, hemostatic anomalies. And it is in this group of patients that you have to consider VTE prophylaxis. As a general rule, we offer VTE prophylaxis to all hospitalized patients. And this is not just from COVID, this is from the pre-COVID era, where there is universal thromboprophylaxis, which shown that it reduced the incidence of DVT and PE by more than 50%. And between the low molecular heparin and the conventional unfractionated heparin, there's plenty of data that shows that low molecular heparin is better. So there is nothing new in that. The issue is how Anyone wanted to speak? Sorry, there are multiple VTE guidelines, as you can see on this chart. And I would like to say that this is an example of a guideline, and we know that the dosage and the treatment varies depending on the patient. You could, if the patient has thrombosis, atrial fibrillation, heart valve replacement, you could consider anticoagulation. However, the prophylaxis could be considered in the non-critical patients. The dosage of prophylaxis can be reviewed if there is no risk of bleeding, patient is obese. In some patients, you may need slightly higher dose of enoxaparin. So instead of 40 subcut daily, you could have 40 subcut BD. And that there's also a role of extended prophylaxis. In the US, the FDA has approved rivaroxaban 10 milligram daily for up to 39 days, and betrixaban, which is another DOAC, also for up to 42 days. In India, you have an option of rivaroxaban 10 milligram daily for up to 2 to 4 weeks, extendable, or enoxaparin 40 milligrams subcut daily. And we know that the oral is preferred by patients rather than subcut injections, and it is also more cost effective. The key question is, would you offer extended prophylaxis to all patients? The answer is no. You offer extended prophylaxis to your patients who would, on clinical determination of various factors, such as the IMPROVE-VTE, such as the score, the SITH score, as well as the comorbidity score, which can guide you in terms of which are the patients. In clinical terms, you've got an obese patient, multi-organ impairment, he's still bedbound, still not walking clearly. Clearly, these are the patients who would require extended prophylaxis. And we already discussed this. We have seen that there is no particular data which shows that a higher dose of anticoagulation is more protective. So you can see the mortality is 14.4 and 38.8 in prophylactic versus therapeutic. But I would like to mention that in this study, the therapeutic dose of anticoagulation was given to more sicker patients, and hence the devil is in the detail. So the more sicker patients got higher dose, and they were already on the way out. In other words, they were quite seriously ill. So there are various guidelines, but to put it safely, prophylactic dose for all patients unless there is a contraindication, higher dose if the patient is obese. Usually, most hospitals will prefer to give low molecular heparin. You have a choice, multiple choices, and if the patient has a history of heparin intolerance, you could consider fondaparinux, which is a synthetic pentasaccharide, and you could also consider extended thromboprophylaxis for patients who are having other comorbidities. And there are various institutional protocols. However, I would like to say that do not go on the basis of just the D-dimer level, because I have seen patients with very high D-dimer levels, but they're perfectly fine. Because D-dimer is not just a reflection of coagulopathy, it is a reflection of immunothrombosis and the impact of inflammation on the lung. So there are various questions still there, and we'll know the impact and the impact of the treatment of COVID, anti-inflammatory, antiviral, in terms of long-term outcome, including fibrosis. And thank you very much, and I'm happy to take questions at the end.
Well,